Hi, I'm Michael Battelle, president of the Fatty Liver Alliance, and you can find our website at fattyliver.ca. I'm here today with Dr. Mark Swain, professor of medicine and head of division of gastroenterology and hepatology from the University of Calgary in Alberta, Canada, and Dr. Naim Alkhouri, VP of Academic Affairs and director of the Fatty Liver Program, Arizona Liver Health. 2021 was a year most of us want to forget. But for a few minutes, I thought it would be great to share what we do want to remember about developments and challenges in the NAFLD-NASH landscape in the past year. So let's start with Naim. What stands out most for you in 2021?
I would say 2021 was a relatively good year for NASH. We learned a lot. We saw some promising data on regression of cirrhosis. We've seen also the results of some trials that were a little bit disappointing, but we learned a lot about how to optimize the readings for liver biopsy and maybe use artificial intelligence. And hopefully, by using digitized images and artificial intelligence, we can reduce that variability in interpretation of the biopsy. But the biggest takeaway for me was a couple of papers I want to discuss very quickly. The first one was a paper we published a month ago in JAMA, looking at patients that had bariatric surgery, weight loss surgery with NASH at baseline. The biopsy was done at the time of surgery, and they all had liver fibrosis F1 to F3. And these patients were compared to patients that did not have surgery, so they had standard medical care. In that paper, we had 650 patients with metabolic surgery and about 500 patients that were the non-surgical control. And they were followed for an average of 7 years, and many of them, they had 10-year plus follow-up. And what we showed clearly in that paper was that in terms of looking at outcomes, so we're not looking at surrogates like biopsy or MRI or liver enzymes. When you look at outcomes, and the two major outcomes were major adverse cardiac events, MACE, which means, developing a heart attack or stroke or dying from heart disease. There was a reduction about 70% in the bariatric surgery group compared to the non-surgical control. And it didn't take a long time to see that differentiation between the two groups. So it was evident within 4 or 5 years. And then when we looked at a new term that was introduced in 2021 called MALO, M-A-L-O, which is Major Adverse Liver Outcomes. I like it because malo in Spanish is bad. And, when you develop these outcomes, it's pretty bad. So what do we mean by MALO? It means progression to cirrhosis, or the development of decompensated liver disease, ascites, encephalopathy, variceal bleeding, or needing liver transplant or dying from liver disease. So we showed that in the surgical group, there was 88% reduction in the risk of developing malo compared to the non-surgical control. And the main major adverse liver outcome was actually progression to cirrhosis. And again, the differentiation happened at 4 or 5 years. The sample size was big, but not prohibitive, because every time we said, let's design trials based on outcomes, everyone's like, oh, you need thousands of patients, you need 20 years of follow-up. And what we showed here, that if you have an effective intervention, you need hundreds of patients, you need maybe 4 or 5 years of follow-up, but it's not 20 years, it's not 5,000 individuals. And I think the other complementary paper, although they have nothing to do with each other, was the paper that was published in the New England Journal of Medicine. First author is Dr. Arun Sanyal, looking at the natural history of NASH and the NASH Clinical Research Network. They followed also a large cohort, about 1,700 individuals, and many of them had follow-up for 10 years or longer. And they showed that the natural history based on fibrosis stage, they looked at a cohort of cirrhotic patients, and they looked at cardiac and liver outcomes. They looked at mortality, but they also looked at progression to chronic kidney disease, which I think is a very relevant outcome when you're looking at patients with NAFLD and metabolic syndrome. They also looked at progression to diabetes and non-diabetics at baseline. And what's emerging here, that maybe what we can do is design trials based on a composite endpoint, where you look at MACE, you look at MALO, you look at progression to CKD, you look at progression to diabetes. And by doing this, number one, you can reduce the sample size and the cost of the trial. but also you are looking at relevant clinical outcomes. We're not looking at meaningless outcomes like NASH resolution that for the patients doesn't mean anything. I mean, you know, if they have NASH on biopsy or not, they feel the same. Ballooned hepatocytes don't make the patients feel any different than having mild inflammation. So I think this was kind of like an aha moment for me that maybe it is time to just push for, you know, a big trial that actually looked at outcomes. And I do believe the cost will not be exponentially higher because you're not doing expensive procedures like MRIs and biopsies. And I think, you know, some of this data will become available as part of the phase 3 trials because it was mandated by the FDA. But everything is, you know, hinging on that interim analysis. So you do the analysis at 12 to 18 months and you have to show histologic improvement. Otherwise, you failed. And my worry is we're going to lose some good drugs if you don't show that histologic improvement. Although if you follow them for 5 years or 6 years, you're going to probably see improvement in outcomes. So this is my spiel for 2021.
Thanks, Naim. Mark, any comments?
I mean, I think that those was really, really great. I enjoyed that tremendously, actually. I'd like to kind of build on that idea. I mean, I think we're just sort of taking these first baby steps in the world of NAFLD, and things are really, I think 2021 was, I agree completely, was from a NAFLD point of view, was kind of a time when things started to align in a new way, and we really started to look at NAFLD differently. We started to think more about outcomes and how can we measure outcomes that we're not, I think it was just so nicely pointed out, was to wait 7 years for an outcome and then have a disappointing result. I mean, that's really how a field gets damaged over the long run, and it can actually stifle progress as opposed to encourage it. So I think that having multiple outcomes that we're looking at in individuals that are very specifically individual but also group oriented, trying to look at a way that we can sort of focus therapies in a more personalized way so that every individual can be looked at and how they fit in this, and all of the different sort of things that make up their MAFLD or their NAFLD really become the targets of therapies, and the outcomes then are driven by what their targets are and what they are as individuals. And I think once we really get to understand these outcomes better and what are the key drivers by really looking both at the whole person, whole groups of people, but also really at very specific things like how the scarring changes in the liver, which is a lot of effort is going to how we can sort of analyze that better and understand that better. I think we're really on the forefront of driving that forward in a way that's going to change how we manage NAFLD going forward. I think there's a lot more papers coming out showing how significant NAFLD is and how it's growing so dramatically. And so if we don't understand this better, we're really going to overwhelm the healthcare system. It'll be not an infectious thing like COVID, but it'll be a metabolic thing that will be like another pandemic that will sort of overrun the healthcare capacity to look after these patients. I think that also in 2021 there was this, I think, medicine often comes in silos, and so people sort of, you know, the hepatologists work here, and the endocrinologists work here, and the cardiologists work here, and, you know, very seldom talk, but and then no one ever talks to policymakers often. And so I think there's also a move where people start to realize this is a disease that just does not affect one specialty. So we need to work together in a way that's best for patient outcomes, and that involves all the way from looking at bench research and new ways of looking at patient samples and trying to figure out what they mean and how to interpret them, linking that to other groups that are doing the same thing with other diseases that are really important for people with NAFLD and MAFLD. Linking those groups together in a way that has a holistic approach to health so that we understand that when we're going forward, if it's not a liver issue, it could be a cardiac issue, it could be some other issue, diabetes or whatever, that we need to be addressing and looking at for overall health of these people. And then we need to link all of that stuff that we find to policy. And so we have to have that flow all the way to the policymakers who can change what we're doing as a society, which really drives much of this in a way that'll positively impact us all. And so I actually am seeing in 2021 the nest being formed with that all happening, and it's actually a very exciting time for NAFLD because we are seeing these pieces which suggest that we can do things that really impact this disease. And when you have cirrhosis, it actually can go the other way. We can do things to fix people that have even advanced disease. And I think the more we look at it in this holistic way and use the information and knowledge of others that are working in the same field but might be in a completely different subspecialty, and then all the way down to basic science, and then all the way up to policymakers, I actually think we're poised to make great strides in the world of NAFLD.
Well, you both did it. You managed to find some great things this past year. I guess my takeaway from what you both said is we need to act now. We need to be inclusive, and we need to have tailored therapy to really think about that. So that basically the bottom line.
And I think that having organizations like yours, which really brings it out to the public, is absolutely key, because it's still not enough is known in the broader society, and I think it gets pushed aside by things like COVID or whatever, which are obviously extremely important. But from a societal point of view, this is a huge issue, and it needs to be, people need to understand it's out there, and that things are being done and things that they can do to help themselves.
We're going to shout it from the rooftops. Sorry, Naim.
No, my message is think outside the liver. I think this is very important. Think about, cardiac outcomes, kidney outcomes, progression to diabetes, and then also think outside of just the medical field, as Mark said, and you have to include policymakers and advocacy groups. And honestly, I think it was a great year for you guys who are advocating for patients with liver disease in general. I mean, I witnessed the, creation of several organizations that are focused on advocating for patients with liver disease. And, congratulations to you, Michael, but also, I became a part of 3 different new organizations helping patients with liver disease, and that's wonderful. And we appreciate what you guys are doing, and we always want to be available to you and advocate for our patients so they feel supported from different angles.
Excellent point. Excellent way to end. Thank you both so very much for 2021, all the help that you've given and awareness that you've raised, and looking forward to 2022 and making an even bigger difference. So thanks so much.
Yeah, thank you. Thanks.
Thank you. Happy holidays.
Yeah, happy holidays. Yeah.